All right, so neuro, we're going to talk about neuro for a minute. I think the hardest thing to get a really good grasp on is the head injury, ICP kind of issues, right? Because it just seems like it's kind of complicated. So high ICP, we're going to put with things like intracranial hemorrhage, ruptured aneurysm, brain tumor, and then just head trauma. So those all have kind of similar results, similar care. And then as far as treatment goes for the patient, you're going to have a neurosurgeon come, and you're going to find out from the neurosurgeon, is it surgical, is it not surgical? So if it's not surgical, so surgical being repair of a rupture. It could be something like a clipping or a coiling or something. So if you have an aneurysm, you have a blood vessel and you have a weak spot, and so the blood travels into this weak spot, and you end up with this big collection of blood here. You have less blood this way, right? And so the blood is all going out here. Well, it's going to take up space in your head. It's going to push on things, going to create increased pressure. So you want to stop that. So when we say clip, and this would be a great thing for you to Google, clip or coil, it all has to do with stopping this process. So kind of shoring up that wall that was weak. So either putting a clip here, a surgical clip, now the blood can't go that way, and your body will reabsorb the blood that's there. Or you can wrap it tight, like an ACE wrap, right, for your brain, so that the blood can't expand. So that's what a coiling or a clipping or whatever would be, okay? So it may be to repair a rupture. It may be to evacuate a hematoma. Patient falls. They're older, they're AFib, they're on an anticoagulant, they fall, and now they've got a collection of blood in their head. Doctor goes in, removes the clot. So that would be a surgical thing. Okay, if it's not surgical, then the doctor's going to look and see, okay, well, if I put a drain in the ventricles, would that be beneficial? Now, if the ventricles are collapsed, it's not going to do any good. You got to be able to put a tube in the ventricles, and then we can drain. So it would be a tube to a collection device and a pressure monitor. Okay, and it's called a ventriculostomy or ventric EVD, which is an external ventricular drainage system.
Those are both surgical?
These are both done by the neurosurgeon, but at the bedside. And so you can Google, I don't know if you saw any videos of it. I have a video I like to show. The doctor will either take a hand drill, like what you see at the craft store, probably much more expensive because it's sterile, you know. But they actually have drill bits and everything. It's kind of weird to be at the bedside and have the doctor ask you for drill bits. Or they have a hand drill where they drill like this, and if you ask a neurosurgeon, well, how do you know when to stop? It's all by feel. So like when we put an IV in and you feel that you're in, that's how they feel that they're in your brain. And they do have to drill through brain tissue, right, to get to your ventricles. So when they take the drill out, there's some of your brain cells on there. So it's kind of like, I hope they didn't lose my R's or something, you know. You can be totally awake. I have had patients that they had cerebral edema. They were a little confused, but totally awake, and I'm holding their head and they're talking to me and the doctor's drilling a hole in their head, and it's like, oh my Lord, because you don't have pain receptors on your brain. So it's all on the outside. So once they put the lidocaine and stuff in and they drill that hole, it's very strange. And then the patient just kind of improves right in front of your eyes. It's really, really odd. So yeah, they'll put that in at the bedside, and then the nurse will have it all primed with, this is just more than you need, but preservative-free saline, so out of a bag instead of a bottle or syringe. We prime it all. There's no pressure bag because we don't infuse fluids in the head. And we attach it to the monitor, and then we get a waveform. And if you work in the ICU, then you get extra classes on how to read the waveform and all that. But it will give us a number. And we want the number to be less than 15. That is millimeters of mercury or centimeters of water, however the physician wants us to measure. And I think I included a picture in your packet of what the whole system looks like. But you'll have it looks kind of like a big, like one of those thermometers that you have outside on your patio. It kind of looks like that. And one side will have centimeters of water, and one side will have millimeters of mercury. They're very similar, but it'll be like, you're like 0, 1, 2, 3, and the centimeters of water is just a little bit off. So you got to know which one the doctor's using to measure, okay? And then there's a zero. You have to zero the transducer just like you do with an A-line, except it's to the ventricle, which is at the outer canthus of the eye, top of the ear. So this is where you would zero. Same exact thing. You open everything to air, have the line ignore the atmospheric pressure, so all you're getting is the pressure inside the brain. Obviously, you have to be even more sterile because it's their brain, right? We do not put chlorhexidine on the brain, on the head. Bad for your brain. We use iodine. We go totally old school with the brain, okay? So you would zero it, and then there's a marker, and you basically have to put it, there's lots of ways. You can either just leave it closed, and then if the ICP goes up, you go in the room, you open it, you drain it. Or the doctor could say, leave it open to drain at 20. So then you leave it open, and you put the little marker at the 20 mark, and then as long as you have it all set up correctly, and because of physics, as long as you have everything set up, when it goes above 20, it will automatically drain, and then it will stop when it's, below that. Or the doctor can say, drain 3 mLs an hour. And every hour you'll go in, you'll open it, and you'll watch till it's at 3 mLs, and then you'll close it. So that's the kind of orders that you would see for a ventriculostomy, okay? So when you get the ventriculostomy in and you get these numbers, you have to figure out your map, which is on your blood pressure reading, or it's also, if you have an A-line, it's really nice because it's going to automatically calculate everything for you. But you're going to figure out your map, and then you're going to subtract the pressure in your head. So this is what we're doing. We're saying, okay, I've got all this pressure up here, and I need this blood to push past the pressure to get into the head, right? So my map has to be high enough to go past the ICP to get in there and bathe the brain in oxygen and everything, right? And to get rid of the toxins. So that's how this math problem is put together. And then this is your cerebral perfusion pressure. So this is really our best measurement for how the brain is being perfused, okay? So let's say we have a blood pressure or a map of 65, okay? So 65 is our map. We got that off our blood pressure reading. We can only get a CPP if you have a ventriculostomy in. It's the only way you can get this number. So if you don't have one in, you can't get that number. Then you have to rely strictly on level of consciousness. Okay, so if you were asked, how do you know that, okay, the drain was put in, you drained some CSF, how do you know the patient is doing better? How do you know that was a therapeutic procedure? You're going to look for a normal LOC answer. like they discuss current events, because that's my favorite. Or patient is alert and oriented times 3. Or patient explains the situation to you, or whatever. You're looking for the normal LOC. It might not say improved level of consciousness. That'd be too easy. And then let's say that in our patient here, Bob, our ICP is 20. What does that make our cerebral perfusion pressure? 45. It needs to be 80. We do not have enough blood pressure, and we have too much pressure that this blood is trying to get into the brain to push against to actually perfuse our brain. Okay? Brain cells do not store oxygen. They do not store sugar. So after 4 minutes, your brain starts to die unless it's given oxygen. This is a problem, right? So this is an emergent priority issue, okay? So along with this, you would see a decrease in level of consciousness, unresponsiveness, that kind of stuff, because it's a really bad number. But this is an okay map, right? I mean, normally we would say, yeah, we're perfusing the kidneys. That's pretty good blood pressure. So you make sure that you guys remember how to do the map, because you might be given just a blood pressure and an ICP. And you got to figure out, do I need to do something? Is this okay? You know.
2 times the diastolic.
So
divided by 3.
it's 1 plus 2 over 3. Systolic pressure is always first on your blood pressure, right? So it's 1 systolic plus 2 times the diastolic divided by 3. That's how I remember. Right? 1 plus 2 is 3. Systolic first. So make sure that you know how to do that, because if you're given a blood pressure, you need to figure out. And you can't always do it by, oh, the systolic's 85, that's not enough. That may not be true. I mean, it probably is true, because usually in a neuro patient, we want their systolic pressure to be 130 or 140. Because again, in layman's terms, and a way to remember, it's going uphill. And it's pushing past a box full of pressure, right? Okay, so that's how the math goes. Okay, it's pretty easy math, but you got to make sure you understand what the implications are. So the thing that we really care about is, what are we going to do about something like this, right? So how do I help my patient? I'm going to erase some of this. This is very difficult to erase. All right, so interventions. So we want to think about, we always want to be thinking about these three aspects of neuro patients: brain tissue, blood, and CSF. Okay? These 3 have to fit into this box. So if there's too much blood, something's got to give. They cannot all be in charge all the time. They have to share space. Okay? So for brain tissue, it could be a surgery where you remove some brain tissue. It could be anti-inflammatory, like Decadron, okay, or dexamethasone, IV push. It could be mannitol or 3% saline. So remember, 3% saline is going to take those brain cells and shrink them into raisins, so there's more room, okay? Mannitol, you're going to use your Osmo, and you're going to give it about every 8 hours. We want the patient to be, do we want them wet or dry? Dry, because if they're wet, they're going to have cerebral edema. That means that all the fluid is going to be up there in their brain, right? So we want them high and dry. So you want the osmo like greater than 296. And the doctor will write orders. They'll say, check the osmo, Q6 hours. If it's greater than 296 or if it's greater than 300, whatever their order is, give 20 grams of mannitol, and then it's going to be checked again. So mannitol, the reason we like it and we're not giving Lasix is because it's cerebroselective. It's smart enough to travel to the brain and just get rid of that fluid. Okay, so this is brain specific. Okay? Now, if you give this diuretic, what are you going to see? What is a side effect of any diuretic? Hypotension, increased urine output, electrolyte issues. Mannitol, you're going to see, it's going to look like what we like to call Lasix urine. It's going to look like water. That doesn't mean it's working, right? What's the therapeutic or intended use of mannitol? To affect the LOC. So you give the patient mannitol. How do you know what's the therapeutic response? It is the LOC. They can discuss current events, right? It is not that they have 2 liters of output. That is not why we're giving it. Yes, that's what you're going to see. That's the mechanism by which we're decreasing swelling in the brain tissue and they'll get better, but we're not giving it so they have more urine output. Okay? So those are some ways that we could affect the brain tissue. Very difficult to do. Okay? Surgery is going to be a burr hole, bone flap, tumor removal, hematoma, evacuation, that kind of stuff. Okay? They're going to make room for the brain tissue. A burr hole, they literally drill holes in your skull to allow, it's very high tech, to allow for brain swelling. Okay? Bone flap, they usually keep in the abdomen, and so wherever that bone flap was is the brain, right underneath there. They don't usually put it back. Patients either swell too much and their brain's gonna it's gonna rub on the edges of that hole, the hole where the skull is, so there's gonna be some issues. Yes?
So will they always preserve it?
The patient doesn't usually live all that long, so yeah, they'll just keep it in their abdomen for safekeeping in case they decide to put it back. But I've seen people walking around the community with the traditional cranny scar and their head's a little bit sunken in. It's because there's no bone there. Okay? So if your patient's having that done, that's kind of, they're at the end of their choices on what to do. Okay, as far as blood, do you have a question?
So the burr hole, since it's just like a small hole,
They drill holes in the head.
So they don't ever put those back in, like fill them in like
No.
little.
Because they're going to put the skin back over it,
Okay.
right? They're going to peel the skin back, drill the holes, and then plop it back on.
Do they put those in your stomach or do they just throw them on?
I don't know where those go.
Those are probably just drilled.
Just
so
like
it's-
little-
yeah, it's probably
That's
just
true.
dust already,
I was
yeah.
just seeing like.
They could probably send something to pathology if they really thought, but no. Okay, so then if you want to affect blood, that's usually with drugs. And that's the blood pressure. So we might vasodilate or vasoconstrict, depending on, do I need to raise the blood pressure? Do I need to lower the blood pressure? Most patients we want to be around 140, give or take. That's to get the blood uphill. Okay? So we might give something like a nipride, which is a vasodilator. Vasoconstrictor, I'm not sure what they're using these days. I'll just put neosynephrine, but we'll see what your book says. And then cerebral spinal fluid, we can only do something with that if they put a tube in there. So we can drain that. Okay? So that is how we affect these three things, right? But there's a list of interventions that are nursing that we can do, especially in the short term, that would make a beautiful select all that apply question if I was writing the test. Okay, so nursing interventions. Oh, and you know what? Over here, no, I'll put it over here. So CO2, carbon dioxide, we want low. So on the lower end of normal, okay? Because CO2 vasodilates. Okay, so this will cause vasoconstriction. So it could be that we hyperventilate the patient. You put them on BiPAP or something that makes them get rid of CO2 more. Change the vent settings so they have more surface area, they have more PEEP, something that allows them to get rid of their CO2 better. Yes?
So the mannitol is a diuretic.
Yes.
But you wrote it under brain tissue.
Yes.
What is it getting rid of?
It's getting rid of the fluid inside the cells.
Okay, okay. Got it.
Yeah. Good question. Okay, and they're probably not going to be on both. You know, it's kind of one or the other. So we can decrease their CO2. This is very temporary. So it's kind of like patient's ICP is 40 and we're trying to get so the patient doesn't crash. Somebody's calling the doctor and you're hyperventilating the patient with an ambu bag. It's one of those because as soon as you stop bagging, their CO2 goes back up, ICP goes back up. So very temporary fix, the CO2 in that way, unless you have a ventilator or something and you can control it.
So decreased CO2 causes vasoconstriction?
Correct, because carbon dioxide causes vasodilation. So if we reduce the CO2, we're going to vasoconstrict less blood in the brain at any given time. So more space, less pressure, okay? We can put the head of bed up at 30 degrees. We need to have a neutral neck. A lot of times the doctor will put a C-collar on the patient just to keep their neck straight. So when you have a patient with a C-collar, it's important that you know, is this because they broke their neck and I could cause them to be paralyzed if I take it off? Or is it just to keep their neck straight, to keep their ICP normalized? And I tell you, it was really driven home when I had a patient where their ICP was going up and it was like 30 something and I walked in the room, patient's laying in bed like this. I straightened their head out and the ICP came right back down. Because it's all venous return, right? The blood is in there and now it can't get back out. So all this blood is trapped in there and there's still blood trying to get in, right? And the brain is swollen and there's CSF and now you've just cut off one area for the blood to get out. It can't get out. So as soon as you set them upright and have their neck neutral, the blood can get out, the blood can get in for oxygen, and your ICP will be better. Sometimes it's as easy as that, okay? Decreased stimulation, so you're gonna have the room dark, you're gonna have low noise. I've had patients...
Adult, cath lab, code blue.
That's the code MI.
Cath lab, code blue.
I've had where I just step into the room, the ICP goes up, I step out of the room, ICP goes down. Kind of like when you're in a room and you know someone's there. Totally bizarre. And then you want to be really careful because everything that this patient does causes an increase in ICP. You suction, they cough, you turn them, you clean up a bowel movement. All of that stuff increases the pressure in their head. You lay them flat. We make sure that we clamp their ICP. And as you can see already, nurses use the term ICP interchangeably with ventriculostomy. So when I'm saying the patient has an ICP in, we all have intracranial pressure. I mean the tube, right? I don't know why, but that's what we do. So decreased stimulation, super important. Sometimes the family is helpful, sometimes they are not. So you may have to tell them you can stay for 5 minutes and then you need to leave because it's causing an increase in their pressure. And you can, play it up like, oh, they're just so happy to see you, they can hear you talking and all that, so you gotta go home, right? Cooling, so hypothermia. Now we don't do the whole code cool thing for them, but you wanna keep their temperature lower rather than higher, okay? Because you're gonna use less energy in your body, less oxygen. Every degree Fahrenheit that your temperature is up, your brain requires like 10% more oxygen. So if our normal temp is 98, patient's temp is 103, that's like 5 degrees. That's 50% more oxygen your brain is now requiring. That's a lot. And you're going to be tachycardic from the fever, so now your heart wants more oxygen. So you're going to have an oxygen problem, which is why nurses are totally on top of the temp. The other part of the problem is when your brain is not working correctly, you can't regulate your temp. So when you have a neuro patient, they're super hot, and then you work and work and work. You do the Tylenol, the cooling blanket, all the tricks. You finally get their temperature down, and it spikes right back up because it's their brain not regulating the temperature, So that's a pretty common thing with neuro patients. So hypothermia, decreased stimulation, neutral neck, head of the bed up, low CO2. They have to have a good airway. Obviously, they need good oxygen, and you need to be able to get rid of the CO2, okay? So those are some things to focus on for patients with any of these issues, okay? As far as drugs go, you got your Decadron. You're saying with me. Nimetop. Or nifedipine. What's that for? What is that? It's a calcium channel blocker. So what is the side effect that you got to still watch for? Decreased blood pressure. That's not why we're giving it, though. We're giving it to reduce vasospasm. So your brain, let's say that you have a hematoma from a fall. And much like a sibling, the brain and the blood don't actually touch, right? There's a blood-brain barrier. They're just kind of right next to each other. So as soon as that blood, now you have an injury, and now your blood and the brain are touching, and the brain's like, ew, it's touching me. I'm going to have a seizure, and I'm going to vasospasm. And then you have a problem, right? So this is to reduce vasospasm, and then you're going to be on an anti-seizure drug for seizures. So yeah, Keppra is pretty common currently, but it could be any seizure drug will do. But yeah, something like Keppra. So that's whenever you have bleeding when the brain and the blood are touching, or you have a brain tumor and it's taken up space and it's pushing on the brain cells, same thing. Your brain gets irritable. It's not supposed to be touched or messed with by anything. It's just a fragile princess. Let me be. Give me my oxygen. I can't possibly hold on to any of that, right? So those are some common drugs. You never, 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 ever give someone with a brain issue a hypotonic solution, because it's just going to go straight to the brain and go, whoop, hydrocephalus, right? So absolutely no hypotonic. Like D5W, you might as well just open up their skull and dump it inside, because that's where it's going to go. Okay? So if you had a patient with a neuro problem, Your patient comes in with a subdural hematoma, and you assess, and it lists, the IV fluids and the blood pressure, and they're getting this drug. Which order are you going to question? A hypotonic, it could be half saline, right? So hypotonic fluids, you would question. I'm sure there's more, but that's what I have right here, okay? So that's the hemorrhagic stroke also goes with this, okay? Hemorrhagic stroke, they don't do well. And it's a very low percentage of strokes. 85% of our strokes are ischemic. So when they come in with a hemorrhagic stroke, it's either really high mortality rate or really high chance of permanent disability. But the people that survive strokes, usually it's an ischemic stroke. Okay, questions about, I know it's like a lot, but